Hello and welcome to Washington Post Live. I'm Frances Steed Sellers, a senior writer here at the Post. Today we're going to be talking about what the future may hold with the coronavirus as we learn to live with it as opposed to trying to purely control or even eradicate it. My two guests today are former advisors to President Biden's COVID-19 transition team. Here's Dr. Zeke Emanuel and Dr. Celine Gounder. A very warm welcome to you both.
Good to be here.
Great to be here.
Dr. Gounder, let me start with you, if I may. Yesterday, I ordered 4 tests, as I know many other Americans did, from the government's website, rapid antigen tests. Help me understand how to use them. How useful are 4 tests for a household, and how do I prioritize their use?
So, with respect to how to use the rapid antigen tests, what the administration is encouraging people to do is really use them if you have symptoms, if you've had a high risk exposure and want to know if you have COVID, or if you're going to be around people who are highly vulnerable. So, for example, grandmother in the nursing home, people who are elderly, highly immunocompromised, living in congregate settings, or are otherwise vulnerable. Testing yourself before you spend time with them to make sure that you're not contagious or infectious and not a threat to them. I agree with you that there are some challenges with respect to distribution. 4 tests is not a lot of tests, and that's why the administration is really encouraging that people use these tests for those very specific cases. And I think one of the things that needs to be looked at is right now it's only 4 tests per household. Some households have many more people than others. And particularly in more socially vulnerable communities, the density of housing is much greater. So that would certainly translate into fewer tests per household. The administration has said, at least in the initial rollout, however, it will be prioritizing, in a sense, bumping up to the front of the line, people who are ordering from the hardest hit zip codes to make sure that people who really need access to these tests are getting them.
Thank you. So, Dr. Emanuel, let me follow up with you. Supposing I had lots of tests, and I know some countries do have lots of tests, how much are they really a means of getting forward? They work for highly motivated people. We know we can get breakthrough infections with Omicron. We're not always around highly motivated people. Are they really a means ahead?
So they are definitely important for fighting Omicron and COVID more generally. But we should be very clear, a test does not treat the illness. The important thing of using a test is try to block transmission from someone who's positive. That's really their use. So as Celine said, if you've been exposed, to test to find out whether you have turned positive and therefore need to isolate to prevent additional spread and transmission. That's their best and most important use. When you've had COVID and you're coming to the end of the 5-day quarantine period, do you test to then determine whether to go back to work or to go back to visit someone? Those are the kinds of situations where the test is helpful. And again, the test is helpful in trying to break the cycle of transmission. They're not helpful in any way because they don't treat the illness.
I want to talk more about this new normal you've been advocating. But first, Dr. Gounder, can I ask you what you hope to hear from President Biden this afternoon, who'll be holding his first press conference of 2022, which marks his first year in office?
I think we'll be hearing about the administration's actions this week to make sure that both N95 masks as well as rapid tests are more available to the general public. I am hoping to hear more about how they will scale up those supplies, and in particular, how they will make sure that more vulnerable people have access as well. And we know many of these people, and I can tell you just from my own experience caring for patients on the wards at Bellevue, many of the most vulnerable people have difficulty navigating a website. Many of my patients who are not vaccinated still are little old ladies who are barely hanging on, trying to live at home on their own, undocumented immigrants who are living under the radar. And it's not because they don't want to get vaccinated. It's not that they don't want to wear masks or get tested. It's that they just don't have as easy access to these kinds of resources. So I would really like to hear How will the administration be addressing those communities in particular?
Dr. Emanuel, that brings me right to a question for you. I know you've spoken out in favor of the use of high quality masks, and I believe you use them with your student or ask your students to use them at the University of Pennsylvania, where people are vaccinated, I think boosted. I think that's a requirement. So are we getting to a point where people who are vaccinated will be tested and also wear masks, and then there's the other half of unvaccinated people without masks or testing? How do we overcome this divide?
Well, let me be clear. I was lecturing, yes, to vaccinated and boosted people, and I didn't request that they wear an N95. I bought them and gave them an N95 and it was a requirement to be in the class because it was 140 people in an auditorium that I think the capacity was 160. So people were shoulder to shoulder. There was no social distancing possible. And that, I think, wearing a mask was very, very important. There were plenty of outbreaks on our campus, despite students being vaccinated and boosted. Breakthrough infections happened, but no transmissions in classes because of being scrupulous like that. I think the wearing of masks, if we have a country where people wore N95 masks, we would actually rapidly bring down the transmission rate. Again, masks don't cure you, but they prevent transmission. They reduce the risk of transmission, especially if people are in close quarters. And I think the administration's announcement today of distributing N95 masks is wonderful. And I'm also hoping it'll establish a new social norm that this is what people have to wear.
So, Dr. Gander, you referred to your experience working in hospitals, and of course, we're seeing this huge surge in hospitalizations. I think likely to increase, certainly the deaths are likely to go up in coming weeks. How has Omicron, which has sort of changed the picture of this virus a bit, how has it made you think differently as an epidemiologist about this virus and what we may face in the future?
I think it's a reminder that every time we go through a surge, we have this feeling of, okay, it's the last surge. Once we're on the other side of this, we'll be able to turn the corner and move on. And I think that was the case early in 2021, in the spring, as we were ramping up vaccination. Again, around the time that Delta emerged, there was that similar kind of psychology. And now again, with Omicron, people are saying, oh, well, this is the last surge. Once we're on the other side of this, we'll be able to get back to normal life. And I think the lesson of emerging variants is that they are highly unpredictable. They throw a wrench in our plans to recover and move on. And I think our new normal should include a strategy to assume there will be at least 1 or 2 new variants per year, and to be prepared for that so that it doesn't take us by surprise, so that we don't have to take draconian measures to control it, but we're prepared to deal with it.
So I spent the morning and some of yesterday on the phone with parents of children under 5 who are expressing great frustration about this sense that we're reaching a new normal because they feel forgotten. I'm sure there's some truth in that among immunocompromised people as well. Other people may be able to move on. They don't feel they can. What's your message to them, Dr. Emanuel?
Well, first of all, they're not forgotten. We have a study ongoing right now by Moderna to try to make sure it can vaccinate children under 5. I know that because my grandchildren are enrolled in that study, and I think it's quite important to find out. We didn't get success with the Pfizer study, and it may be because of the dosing range. It's hard to know. I don't think they're forgotten at all, and we're continuing to collect data. We should remember that young kids generally do not suffer seriously and severe disease from this. That doesn't mean every child is fine and going to be fine. And we have to understand which children are more likely to be affected and not. And we do have to have a population-wide policy, and I think we are trying to do that. We're developing therapeutics so that people who are immunocompromised or people who can't take the vaccine for one reason or another, young kids, can get treatment if they get COVID. That's very important. We right now have 2 drugs, but we need to develop other oral agents so we can have a multi-drug cocktail just like we do for HIV. all of these are measures that are really important to protect this population. I would add one other measure that can work in the background that I think we haven't emphasized enough, that can really also make a big difference, not just about COVID, but all viral respiratory illnesses. And that is better indoor air filtration systems. We know that this virus is carried on aerosols, and that if we filtered the air more frequently with MERV 13 or higher filters so that it would extract these small virus particles, that would reduce, again, transmission. And that would be very important. So mandating public buildings, schools, other venues, restaurants, bars have that kind of ventilation. And if they can't get that ventilation, have HEPA filters, would make a very big difference for children, immunocompromised, frankly, all of us.
So these measures, these broad measures, sound epidemiologically very sound. But we're in a situation where, for example, last week, the Supreme Court blocked the president's vax or test measures for companies over 100 people. Dr. Gounder, how do you face the sort of political realities as you talk about what's, as I said, sound like very epidemiologically sound measures?
I think that it's clear that we're not going to hit 85, 90% of the population vaccinated in the US anytime soon, if ever. And so that really hammers home that although vaccines remain our number one, number two, number three most important tools in our toolbox to combat COVID, we really do need to be looking at other measures and employing those at greater scale. So that includes many of the things we've talked about, making more use of rapid tests so that people know when they're contagious, when they're a threat to others. Increasingly, those rapid tests should also be used to help get people on treatment. So drugs like the new Pfizer Paxlovid drug, which will be available more widely in the coming months. Those drugs could be game-changing, but people need to have easy, quick, free access to testing that then channels them, links them to treatment very quickly. And then finally, as Zeke was saying, other measures like ventilation and air filtration, which are really important because they do not rely on individual behavior and can also be a place of public-private partnership to scale up those kinds of infrastructure improvements in public buildings and elsewhere.
Can I just emphasize one?
Yes, I want to follow up with you.
Can I just emphasize one thing that Celine was exactly in what she said, but just to really put it home. The best way to protect kids under 5, to protect the immunocompromised, is to disseminate vaccinations throughout the population and bring the case count and the circulating viruses down so that there's a lower chance that those vulnerable groups will be exposed to virus. We're not getting to zero, we're reducing the risks. And that, I think, is a very important psychology. Parents who, in the past didn't obsess about the flu, they just went on their business. When we get down and there's not that much COVID, it's not going away, but it's present at a much lower level. And the people who get it don't get hospitalized or die at a very high rate. That actually should allow us to get to a new normal and allow parents to ease up. And the best way to get there, again, is vaccination and reduce the ambient rate of the coronavirus circulating.
But Dr. Emanuel, I really want to follow up on this. We've had this setback last week for the Biden administration's vax or test mandate in big offices. Are there other levers the administration should pull? Are the president's hand tied, or do we look at vaccination for domestic air travel? I don't know. How do we make this politically possible for the president?
So first of all, I think you're revealing something very, very important in the way you asked that question, which is the Supreme Court ruling was not really a legal ruling. It was a very political ruling. And that is a serious, serious problem. I think we need to do 4 things, and the president can try to do 4 things. The first is we have some mandates that OSHA can do, and it did appear that the Supreme Court left open more targeted mandates where workers are necessarily exposed, where there's documentation. So, for example, in the meat processing areas. So a more targeted OSHA ruling may go through. Second, as you point out, the federal government does control interstate travel, and making it safe through requiring vaccination is something that I've been advocating for months and months and months, and I think that would be a very important change. Three, we can work with states to vaccinate children between 5 and 18 in schools and make COVID vaccine a requirement, just like tetanus, just like diphtheria, just like measles, to going to school. I think that's very important. We've got plenty of federal aid going out, and you can tie the federal aid to these kind of requirements. We know that that's legal. And I think we also need to be aware that there's a lot of misinformation out there. There are many reasons people don't get vaccinated. Only 15% of the population is really committed to not getting a vaccine. There are many more people, about 20% of the population, who are perfectly willing to get vaccinated, but for a variety of reasons, like Celine mentioned, hard to navigate a website, not knowing where to go. We need to get to them, and we need to, among other things, remove the misinformation that is keeping them back. That's going to require tackling big tech and the misinformation machines that are Twitter and Facebook and Instagram and all of those other platforms that allow people who have a faulty view to keep hearing that faulty view rather than to begin hearing the facts. Getting people out of their information bubble is going to be critical to breaking the misinformation trap.
Well, we're going to leave it to legal scholars to look back on that ruling. But Dr. Gounder, I do want to ask you about building trust in the vaccines and masks. Are there strategies you have in your head that have not yet been employed that could make a difference to these numbers and in public confidence?
The administration has employed a number of different approaches, beginning with trusted messengers from inside communities. Over the summer, you saw the summer of incentives, everything from beer to travel to tickets to certain events, and then finally mandates more recently. I do think the trusted messenger approach continues to be a really important tool. Very often, who is delivering the message is more important than the message itself. And hearing that you should get vaccinated from somebody you trust, I think, is still one of the most important levers that we have. The challenge is that many of the trusted messengers that were identified that helped with vaccine rollout in the spring, in the early months of vaccine rollout, were very much targeting communities of color, other vulnerable communities. And based on what we're seeing at this stage, among the people who are the most intransigent about getting vaccinated, various organizations have done polling looking at this, including the Kaiser Family Foundation, and there's clearly a partisan divide in some of those attitudes. And we really need people on both sides of the aisle, trusted messengers, reaching out within their own communities because they're the only ones who are going to get through.
We've seen countries across the world take very different approaches to how to encourage people to get vaccinated. I have a question that's come in from the audience. It's from, let me see, Ruth Morelli in Pennsylvania. And Ms. Morelli asks, are there any nations you look at as models of coronavirus containment? And maybe Dr. Emanuel, you can start with that one.
Well, I think there are lots of countries that have done reasonably well. Denmark, Portugal, Israel, and they have, by and large, first of all, they're united in fighting pandemic COVID, and they don't have this sort of politicization, polarization. And we can't underestimate how devastating that has been when senators, governors like DeSantis or Abbott in Texas impede federal efforts to try to get this under control and really undermine it. Second, they have been able to dramatically increase the proportion of people who were vaccinated well over what we are, and close to 90% in many of those countries. And getting people vaccinated and boosted makes a very big difference. And in those countries, as I think you pointed out and hinted at, trust in the public health message has been critical. I have to say, our CDC has been less than good at engendering trust by the population because of its confusing announcements, its changing announcements, and that really does need to change on the federal government level. We know that trust is very heavily correlated to actually outcomes and containing COVID and getting the incidence rate down. Again, let's remember for the audience, we're not getting it to zero. It's going to be here with us forever, as far as certainly for our lifetimes. We're going to get it low, and that's going to be critical.
Dr. Gounder, it's easy for us to sort of sit around and be critical of things that have happened in the past year. And I know President Biden's approval ratings are not great at the moment. But tell me, what's gone right?
I think the first 6 months or so of 2021 went astoundingly well, with the way in which the administration rolled out vaccines, stabilized vaccine manufacturing and supply, distributed the vaccine to the states. That was really efficient. And if you look at the numbers of vaccinations, shots in arms that were being delivered per day in April of 2021, it was truly amazing. 3-4 million, I think, at the peak in a day at a time. And so I think the administration really performed outstandingly well on that. I think where we ran into issues was around June, July, when I think a lot of people were starting to drop their guard, lower their guard, thinking that we were almost mission accomplished with respect to the pandemic. And this is around the time that the Delta variant hit, that we started to also see breakthrough infections. And I think that really shook many people's confidence in our public health control efforts. That should have prompted a reset, something that we're finally seeing now. But at that time, we should have had a reset with respect to, should we only be focusing on vaccines, or are there other tools we should really be trying to implement at scale at population levels now?
So, Dr. Emanuel, when and why did you decide to write this, or co-write this series of articles calling for a new strategy?
Well, a group of us have been meeting every Tuesday to share data, share our perspective on the results that have been published, and try to understand where things are going and what policy recommendations would be best. And I think sometime around October, we began to gel that, this idea that seems to have gotten hold in the country of, we're going to eradicate COVID is wrong. We need to reorient the country towards a much more realistic goal, the goal of living with COVID, and then think about what are the strategic policies that we need to put in place, both to get there and to sustain our living with COVID. And it was that reorientation that the fact that we thought the country needed that, and the sort of baby steps to a strategic plan that we thought would be helpful, again, for everyone in the country. The whole country needed that reorientation, not just the administration or not just some parts of the country. And so that was what really impelled us to come together and to try to write these three viewpoints that were published in JAMA.
Dr. Gounder, one of the groups of people I know who've reacted certainly to me about the notion of living with COVID is people who are living with long COVID. What's your assessment of the risk going ahead if this disease continues in an endemic form, or to have major surges in coming years?
I do think we need to take those concerns very seriously. There's still a lot that we don't know about long COVID. The NIH has launched a large research program into long COVID, but we don't have a lot of data out of that yet. I will say what we know about vaccines and long COVID is very promising and reassuring, in that people who have been vaccinated are less likely to develop long COVID if they have a breakthrough infection after vaccination. And we're also seeing increasing evidence that if you vaccinate somebody who has long COVID, that can help reorient the immune system and essentially help treat them for long COVID. But I think, going back to why we're talking about a strategy about living with with COVID, is that this is not a virus you can eradicate. This is not smallpox. There are non-human hosts The incubation period is very short. Smallpox has an incubation period of 14 or so days. With SARS-CoV-2, with the Omicron variant, it's 2 to 3 days. There's a lot of asymptomatic transmission with Omicron and the other SARS-CoV-2 variants that you did not see with a virus like smallpox. And strategies like what we called surveillance and containment, or ring vaccination, that were used to great success with smallpox, because you could recognize somebody, even a layperson could recognize a case of smallpox, alert the authorities and make sure everybody who come into contact with them were vaccinated. That is not possible with an infection like SARS-CoV-2. And so the reality is, as much as we would like to jump in a time machine to October, November of 2019, that is not feasible. And so we wanted to help get people thinking about what is a strategy that will allow us to coexist with SARS-CoV-2 in the long run, to make sure that we're protecting the most vulnerable through a public health approach, and that we change our health systems so that they're not crushed by the burden of COVID in the future.
So thank you both so much. I'm afraid, Dr. Manuel, we're running right out of time, which is a shame. But we'll have you back. That's the answer, right? Thank you both so very much for giving us a sense of what that long-term strategy is. We are out of time. Thank you for joining us.
Thank you. It's been a great pleasure.
Thank you.
I'm Frances Steed-Sellers again, and if you want to see our future programming, please go to WashingtonPostLive.com. That's where you can find it. Thank you for joining us today.